Good afternoon, everybody. It is my pleasure to introduce Dr. Lucy Godley. Dr. Godley received her scientific training at the Marchesi, Wiley, and Varmus laboratories, which are located at Yale, Harvard, and UCSF NIH, respectively. She received her medical training at Northwestern University. She then completed internal medicine and hematology oncology training at the University of Chicago, where she held a long-time faculty position before relocating to Northwestern University in May of 2023. She's currently the Jeffrey and Marianne Silva Family Professor of Oncology, the director of the Silva Family Blood Cancer Institute, and the clinical director of cancer genetics for the Robert H. Lurie Comprehensive Cancer Center and Division of Hematology Oncology. Dr. Godley also runs an independent research laboratory focused on understanding the molecular pathways that drive hematopoietic malignancies, especially how germline predisposition alleles contribute to individual and family risk. Dr. Godley's work has led to the recognition of numerous germline variants and understanding how they contribute to hematopoietic malignancies. Along with David Wu at the University of Washington, Dr. Godley co-chairs the Myeloid Malignancy Variant Curation Expert Panel, which has provided variant curation rules for the RUN-X, which are now in use throughout the world. Dr. Godley practices bench-to-bedside medicine that advances patient care through deep appreciation of the latest scientific findings. Please help me welcome Dr. Godley, who will be presenting on germline predisposition to hematopoietic malignancies. Dr. Godley.
Thank you. Is the microphone working okay? Yeah, perfect. All right, great. Well, thank you all for having me. It's a real, whoops. Sorry, did I do that? It's such a pleasure to be back in Miami, especially because I come from Chicago where it's still very cold. So it's just wonderful to be here. I got to meet with Dr. Weiss this morning. Dr. Weiss was my first attending when I was an intern, day one. So can you imagine, he set the bar for me, what an attending is. So it was really such a pleasure to work with him. You're just so honored to have him here as your chair and Mikhail as your division chief. So it's such a pleasure to be here with such good friends. I'm going to talk to you about my interest in germline predisposition and hopefully inspire you a little bit to think about the germline. This all started in the clinic when I was a first-year hematology oncology fellow, and I saw my leukemia patients with myeloma and stem cell transplant, and I talked a lot to my patients. I heard their personal histories, which often involved multiple cancers, and their family histories that were just riddled with cancer. And at the time, inherited cancer risk was a thing for the solid tumors, and I felt like I was being swatted down like a little fly when I would say these people have to have inherited cancer risk. Look at their personal and family histories. And I was told that's a thing for solid tumors. It doesn't exist for the heme malignancies. And I think it's not true. I actually think it's much more common in the heme malignancies, and I don't know why there has been a feeling that the blood cancers are somehow so different from the solid tumors. They're not. They're just cells growing out of control. And all the pathways that are essential to cell growth in solid tumors are at play in the heme malignancies as well. So hopefully by the end of this talk, you'll all agree with me. This is the thank you note that one of my, I don't know if this is working or not. There we go, a little bit. This is the thank you note that the daughter of one of my patients gave to me to thank me for caring for her mother. It's supposed to be a picture of me doing a bone marrow biopsy on her mother. And I love the way the arm just becomes the needle. It's just so fun. And she was about 7 when she drew this. She had never been in the room before, but she got it pretty close. But really, I thank the patients because without being in the clinic, I wasn't studying this at all. I was studying basic epigenetics. And it was really the patients and the families who kind of showed me this whole field. So I'm very indebted to them. And in the lab, we have a lot of people who are working very hard to understand how these inherited cancer risks give us tumors, both in the Blood Cancer Institute group that I run to foster translational work, and also these people here listed in the middle who are in the research lab. So I have this idea that if we understood people at multiple levels, we could really devise appropriate therapy for them. And those different levels start with the germline, start with the DNA variants that you're born with. And a lot of those are affecting the epigenetic changes in all of your cells. And then as you go through life, you're acquiring DNA changes or DNA mutations in all of your stem cells. It's just really hard to measure that because in most of your organs, the stem cell, like you think the crypts in the colon, they just make the local cells around the stem cell. They don't move around the colon. But peripheral blood is absolutely unique. Peripheral blood is the output, the pooled output of all your active stem cells. So if you sequence the blood, you're looking at all the stem cells at once. There's no other organ that allows you to do that. And so if you just take blood from all of us or people walking around, you see that people are acquiring DNA mutations in their blood stem cells. We now give a special name to that form of somatic mosaicism. We call it clonal hematopoiesis, but it's just lineage-specific somatic mosaicism. And then on top of that, more changes happen. We call that, tumor profiling, right? You probably all, when you have tumors now, you're sending next generation sequencing and chromosome analysis, and you're kind of putting the ontogeny of the tumor together in your mind. And the last element that I feel like we're not really doing yet clinically, but is very, very important is the microbiome. And it's the state of the immune system. So all of us have billions and billions of bacteria and other organisms on our skin, in our gut, in our lungs, everywhere. And those organisms are producing chemicals that have real effects on our cells. And I think in the future, we'll be dialing that, modifying that microbiome, modifying the immune system, which obviously we do in stem cell transplant and cellular therapies, but I think we'll do much, much more in the future. And if you really understood all of that for someone, you could really devise a very tailored therapy. So hopefully that's not too far off what you all believe in as well. Now, the germline predisposition, when I started working on it, really in earnest in 2010, 2011, was, as I said, not a thing. But fortunately, that landscape has changed, and germline predisposition to the myeloid malignancies is now very well recognized by these different classification schemes and guidelines. Actually, I think germline predisposition to lymphoid malignancies may be in number even more frequent. It's just not as well studied. And that's something that all of you could work on and make more impact in the field. This is how I devise or sort of categorize the genes right now. In the column all the way to the left, you have genes where deleterious variants confer risk for myeloid malignancies. Then in the next column, lymphoid malignancies or immunodeficient states. And I do have a bias that immunodeficient states are themselves predispositions to lymphomas or other lymphoid malignancies. Then in this third column, risk for either myeloid or lymphoid malignancies. And in this last column, really all cancers, solid tumors, myeloid, and lymphoid malignancies. And genes tend to move from the left into the right column. So all of these disorders, when they are first described, you have an ascertainment bias. You have clinicians who've seen certain tumors in people with DNA changes in that gene, and then people look for that when they see their families. But as we do more agnostic sequencing, we find that the tumor spectrum is always larger than what was initially described. I have a little bit of a fight going on in the BRCA1 and 2 field that I'll talk to you about, because I think the blood cancers are a direct consequence of germline BRCA1 and 2 variants, and that is not accepted, I would say, by the people who've been in that field for a long time and think about it again on this solid tumor side. So there's this riddle in English that goes, how much does a ton of feathers weigh? Of course, you're giving the answer, it's a ton. This is sort of my way of showing you how common this phenomenon is. So in parallel to that riddle, I show you these feathers where each feather is a different disorder. And just like you can have so many butterflies that branches of trees break off, right? Each butterfly is very light, but in totality, something is very heavy. Similarly, each one of these disorders may be relatively rare, but there are so many of them that this becomes a common phenomenon. And that's a challenge for diagnosis because you have to be able to look at many, many genes. And how do you do that? We'll talk about that. And you can see some of these feathers are larger at the bottom. That's just to show you that bone marrow failure, just keratosis congenita, is comprised of many, many, many genes. So if you think about that from a platform diagnostic point of view, this is really challenging and really begs an exome or genome-based platform. So I believe that all cancer is kind of a mix of inherited predisposition and environmental insult. And there's a layered effect of those. There are some germline predisposition disorders that are so penetrant, you don't need much environment. Those would be 5' N CEBP alpha mutations. So if you had a child who was 3 years old who had a 5' N CEBP alpha mutation, I would argue to transplant that individual as young as possible, because the penetrance of that disorder is 100%. That person will get a myeloid malignancy at some point in their life. And if you know that, why wouldn't you fix them right from the start? There are other environmental insults that are so strong that you probably don't need much germline. And those would be large dose radiation exposures, which I used to think, like, I wouldn't really see as a clinician. But it turns out a lot of Chernobyl survivors came to Chicago. And a few months ago, I had a woman who's now 40, and she talked about when she was 3 years old in Ukraine being downwind of the Chernobyl disaster and spending a month in the hospital, vomiting, her hair fell out. She described acute radiation sickness. And now she has cancer, and she's wondering whether that was due to her environmental exposure or whether she had inherited predisposition. And interestingly, she tested negative for germline predisposition. So it may be that her radiation dose was enough to give her cancer risk. Most of the time, people's cancer is probably a little bit of both. I want to start with a case, and this is a real case, and it really kind of showed me how much you could do of this understanding of this layering, so to speak, and how much people really are interested in research and the latest findings. So this was a colleague of mine from University of Chicago who was diagnosed with breast cancer. And she was in her early 60s at the time. This was diagnosed from a routine mammogram. And you can see her, she's the red arrow person. You can see her family history, had some cases of breast cancer, but not below the age of 50. 50 is usually the age people use for, under that age is young onset. So these would not trigger the idea of young onset breast cancer. Her grandmother had the ovarian cancer, again, in her late 60s. But based on this clustering of breast and ovarian cancer, it was recommended that she have germline testing, which she did. And she was found to have this CHEK2 I157T, or you may know it as I200T. It's the same change, it's just a difference in how the numbering goes. And this change is the most frequent one that we see in Chicago in families with inherited CHEK2 changes. In people with blood cancers. And if you are a solid tumor, again, not to divide us, but breast cancer doctor, you call this a risk allele. Or you might even have a clinical report from a testing company that calls that a risk allele. They don't even call it pathogenic or likely pathogenic. In ClinVar, it's listed as a conflicting variant, meaning that some companies call it uncertain significance and some companies call it problematic, which is problematic in and of itself, right? That not all companies call it the same thing. So that's what she was found to have. And she came and she said to me, Lucy, I'm not having any therapy at all for my breast cancer until you tell me what happened to your mouse. And I looked at her, I said, what do you mean? She said, well, you made a mouse with this change, didn't you? And I was stunned. I had no idea that she was ever in any seminar where I talked about the mouse that we had made. We did make a mouse with this allele, a knock-in allele. I'll talk about the mouse in a minute. And the reason we had done it was because, again, in the solid tumor field, this is a weak cancer risk. But if it's the most common CHEK2 variant we see in people with heme malignancies, it doesn't seem to be so low risk when we look at it from our lens. So I decided we make a mouse that looks like people and just see what happens to the mouse. So let's take a break for a moment from the case. I'm going to tell you what we know about CHEK2, and then I'll come back and tell you what we did for my colleague. So when we see people with heme malignancies that have a personal history of multiple cancers, or they have a positive family history, we come upon this DNA repair pathway again and again and again. It's homologous recombination DNA repair. You know it well. ATM recognizes double-strand DNA breaks and activates CHEK2, and then CHEK2 slows or stops the cell cycle to fix the problem by activating P53, BRCA1, BRCA2. And we talked about clonal hematopoiesis. Think of clonal hematopoiesis as kind of like step one on your way to getting leukemia. So people have done global genome-wide association studies looking for DNA changes out in the general population that give people a risk of developing clonal hematopoiesis. And interestingly, you see the Empire State Building there is TERT, which encodes the protein component of telomerase. So that's a really interesting finding. But then you see ATM, you see CHEK2, you see TP53, you see a lot of the components of that homologous recombination DNA repair pathway. You see a lot of other genes that we know have germline predisposition as well. And that kind of maybe argues that those germline predisposition disorders cause heme malignancies via clonal hematopoiesis. So if you have a germline CHEK2 change, you are at risk for clonal hematopoiesis. This is kind of I should put in a more current view of our cohort of individuals who test positive for deleterious germline CHEK2 variants in Chicago. And you can see, that's on the right, you can see that pileup of people who have that I157T or I200T. Half of our families have that same allele. So again, it doesn't look very weak when you look from the lens of a heme malignancy. And on the left, you see, this is pedigree number 1 for the CHEK2 cohort. The arrow, again, gives you the proband. She was a 35-year-old woman diagnosed with MDS. I think today, just her age, even just her diagnosis of MDS, would give her germline predisposition testing. It wasn't a thing at that time when she was diagnosed, but she's very smart. She lives in California. She's a dermatologist, a physician. And she said, why is a 35-year-old woman getting a 70-year-old person's disease? What's the deal with me? And so she came to Chicago and had germline testing. And as I said, she was family 1. She decided at that time, I'm only getting older. I'm a risk factor for MDS. I already have MDS, risk factor for AML. I'm just having a transplant. And so she had an unrelated donor transplant, did well from that. A year later, decided, well, I have this germline CHEK2. I fixed my bone marrow system with my allo transplant. Now I have to pay attention to my solid tumor risk. So she had a thyroid ultrasound. First she had the breast MRI, and she had a small breast cancer in her left breast. She had bilateral mastectomy at that point. Then she had her thyroid ultrasound, had a thyroid cancer. So these people do feel a bit like whack-a-mole. You treat one cancer and they live long enough to get another. But she looks at it that we've saved her life 3 times because she never would have had any of that treatment had she not known about her germline CHEK2. You can see that her mother had multiple myeloma. She had an uncle with a B-cell lymphoma and a great aunt with breast cancer. So again, this mix of solid tumor, myeloid, and lymphoid cancers. And this is very typical for these families. Now, some of you who might know a bit about Chicago and the immigrants in Chicago will know that it's the 2nd largest Polish city in the world. And you may know that CHEK2 mutations are very common in the Polish population. So you might say to me, the only reason why you see CHEK2 is your little Poland. So we did this burden calculation to say, if we are pure Poland, which we're not, completely, but if we argue by statistics we're pure Poland, are we just seeing CHEK2 because of our population? And the answer is no. You can see the odds ratio here. Sorry, the pointer's not working too well, but you can see the odds ratio there for that I157T or I200T is 5. It's actually higher for the Ashkenazi Jewish founder S428F variant, odds ratio of 22. And interestingly, we really didn't see statistical significance for the Del 1100C, which is the CHEK2 allele probably strongest associated with breast cancer. So that suggests that different CHEK2 variants kind of are stronger or weaker in different tissues. Context matters. We kind of knew that. And so we're not just seeing this because we're little Poland. We think it's because the gene variants really predispose. And we've done this essential calculation from UK Biobank now as well. Some of you may know with UK Biobank, we have full sequencing on about 500,000 people in the UK. We can pull out everybody with these variants. These 3 variants make up the majority of individuals in the UK Biobank who have deleterious CHEK2. And we can say, are you more likely to get breast cancer, heme malignancies, any other kind of cancer? Because we have all their diagnosis codes. And the answer is germline CHEK2 variants cause breast cancer, prostate cancer, we knew that, myeloid malignancies, and lymphoid malignancies. So we can see statistical significance from UK Biobank as well. This is just a chart to kind of go through again that you see myeloid, lymphoid, solid tumors in these families. It doesn't matter what order the myeloid malignancy comes in. It can be primary, it can be therapy related or secondary. And you see the ages are distributed throughout the entire age range. You'll hear that theme. I am a little bit fascinated with the age idea because I think in cancer risk, we have this assumption that if you have a germline variant, you're going to present young. And sometimes you present young, but sometimes you present exactly in the same age range as everybody else. And the age at which you present is just a surrogate for the pathway. If you have an inherited risk and a pathway that takes you there very fast, you present young. But if it takes longer, you present as an older person. And CHEK2, actually your risk is pretty even across your entire life. Now, we looked in the myeloid malignancies to see, is there any signature that you had a germline CHEK2 mutation? Is there any point mutation or other signature? And the signature ends up being cytogenetic. You're more likely to have a myeloid malignancy with a reciprocal translocation. And that makes sense because this pathway detects double-strand breaks. So if the pathway doesn't work so well, homologous recombination doesn't work. So if you think about it, if you break chromosome 9, for example, you break chromosome 22, you have an intact chromosome 9. You have an intact chromosome 22. You should be able to put the pieces together and stitch them together correctly. You shouldn't make the 922 translocation, the 1517 translocation, the 821 translocation, et cetera. So you are more likely to have a cytogenetic signature with germline CHEK2 mutations. Now, what about that mouse? So in people, you can be heterozygous or homozygous for these CHEK2 variants, and likewise for the mouse. So this mouse is nothing fancy. It's a knock-in mouse. So it either has the I161T, which is the equivalent position in mouse CHEK2. You can breed it to homozygosity without any problem. And we put the mouse on the shelf and we said, does it get breast cancer, prostate cancer, colon cancer, thyroid cancer, or blood cancers? And we were, in the end, we were biasing a little bit because we were bleeding the cohort every month. And I didn't think that bleeding the mouse every month to do a CBC on the mouse was a big deal. But it turns out even bleeding the mouse is a little bit of a stress on the bone marrow. It's making the mouse a little bit anemic. And by doing that, you force the stem cells, the hematopoietic stem cells, to go through cell division. And that's where all the problem happens. Because when they go through cell division, they make mistakes and they can't fix them. So by bleeding the mouse every month, we're actually stimulating the hematopoietic stem cell, and that's when they get into trouble. And we were benefited here, I have to say, by COVID, because COVID hit right at the year mark, the 12-month mark. And so I think probably if COVID hadn't happened, we probably would have just sacrificed the colony. After a year, my goodness, if nothing has happened, and the experiment just didn't work, right? But you can see everything starts to happen after a year. They start getting sick like clockwork after 15 months. So from 15 to 24 months, they just start dying. And they die of heme malignancies, it turns out. Now, along the way, you're going to ask me if they get clonal hematopoiesis, right? Because if you remember the GWAS study, they should be getting clonal hematopoiesis along the way. But this, we did not answer in the best way. We didn't address it in the best way. Because remember, the cohort was being bled every month. But when the human GWAS came out, we didn't have any blood saved from these animals. So we have to start all over again. And this experiment takes 2 years, so it's an investment. So the way we tried to answer it was just taking mice that were on the shelf, just living their happy life for 9 months. They weren't being stimulated by CBCs. The answer is these mice, if you just let them live on the shelf at 9 months, there is no clonal hematopoiesis. But now we've gone back to do the correct experiment, which has been an investment in time. So now the mice are getting sick. They're between 15 and 24 months, and we have DNA saved along the way. So the question will be to molecularly profile the leukemias, lymphomas that have developed in the mice, and then go back to the old bloods that we collect along the way, the DNAs, and see if there was clonal hematopoiesis. So I can't quite answer this for you yet. But I've given you the answer. They develop all kinds of heme malignancies. They develop T cell, B cell, myeloid. These are true malignancies. They grow in secondary hosts. They're karyotypically abnormal. And so I think this work is almost accepted for publication, so you'll see it soon. And I think this will establish CHEK2 as a true risk factor for heme malignancies. We've been interested in this pathway for quite a long time because back in the day, BRCA2 was known to be a Fanconi anemia gene, but BRCA1 was not recognized similarly. So we had done, this is a lineage-specific knockout, a bone marrow-specific. I put it in air quotes because it's using the MX1 CRE knockout system, which actually knocks out BRCA1 in many different tissues, including the bone marrow. But if you transplant these stem cells that are deficient in BRCA1, they reproduce malignancy in the secondary host. So we do think this is driven by the knockout within the stem cell. And these animals got all kinds of heme malignancies. You can see they're mitomycin C sensitive, just like a Fanconi malignancy would be, very karyotypically abnormal. And this work, along with some people with biallelic BRCA1 mutations, established BRCA1 as FANC-S, and it's now very well recognized to be a Fanconi anemia gene. So if BRCA1 and 2 are both Fanconi anemia genes and risk factors in that biallelic setting for getting heme malignancies, is it so crazy that a single allele could also give you risk for heme malignancies? I didn't think so, but that's been, it's been a struggle. So we did kind of the same description, again, with the lens of heme malignancies of our patients in Chicago who have germline BRCA1 or 2, cancer risk alleles. These are well-documented alleles, and the heme malignancies that they develop. In the literature, you'll see a lot of comments that these malignancies are secondary, therapy-related. So someone had breast cancer, got treated with radiation chemo. Again, that's the environmental insult. Then they develop a therapy-related leukemia. It's small here, but those of you in front might be able to see that half the time that heme malignancy happens first. And if you recall the logic from the germline BRCA1 and 2 back in the day, arguing that they cause breast and ovarian cancer, the argument went, well, the germline allele is causative to those malignancies because in the cancer itself, you knock out the other allele, what was the wild type allele. So you have somatic mutation of the wild type allele. And we show the same thing in these heme malignancies. Again, it's typically cytogenetic. So you're usually having a deletion of the other chromosome and knocking out the other allele. But somehow now that's not enough of an argument. So some of you maybe in the discussion section can help me understand why it's not so accepted that these heme malignancies are direct consequences of the germline allele. The other thing those of you in front can maybe see is that BRCA2, there's the red arrow, BRCA2 is a very strong risk factor for multiple myeloma. In fact, all lymphoid malignancies. Again, if you're in a hemonc clinic and you're seeing the selection, the people who are diagnosed with these diseases, you will not be surprised by this. But it's harder for the, maybe for the breast ovarian cancer group because, again, these heme malignancies are rare malignancies. So it's only a subset of those patients who are developing them. But this is strong. So we recommend baseline bone marrow biopsies for our individuals with germline BRCA1 and 2. And I can tell you, a few months ago, we had a 72-year-old retired physician who has BRCA2. He was getting mammograms and all the solid tumor surveillance. And I told him about our work. He said, oh, I'll have a bone marrow biopsy. And he had 10% malignant plasma cells in his bone marrow. He had smoldering myeloma. So we think this is quite a strong risk factor. Again, you get solid tumors, you get myeloid malignancies, you get lymphoid malignancies. It doesn't matter, again, the order of those, just like we saw for CHEK2. We did the same burden calculation, not saying we're Little Poland, but saying we're a pure Ashkenazi Jewish population in Chicago. Is that the only reason why we're seeing these alleles? And here you see the odds ratios are even higher than what we saw for CHEK2. So the answer is no. Now we're doing the same UK Biobank calculation for BRCA1 and 2. I think it might take that to convince the germline BRCA community. We'll see. So what did I tell my colleague when she said, I'm not having any therapy for my breast cancer until you tell me about CHEK2? Well, I told her, you're at risk for clonal hematopoiesis. And if you already have a TP53 mutation, then when we give you radiation or we give you chemotherapy, we're going to select for that clone. We're going to select for a therapy-related leukemia. So I recommended that she be tested clinically for clonal hematopoiesis. And she did. And fortunately for me, she did not have it. And so she felt like she just did not want any kind of radiation, especially because radiation, of course, causes double-strand DNA breaks. And so she elected to have bilateral mastectomy. She did get cytotoxic chemotherapy, but we're following her very carefully for clonal hematopoiesis. And I think the harder question is, what would you have done if she had TP53 mutant clonal hematopoiesis to start, or any other kind of clonal hematopoiesis, but especially TP53 mutant? These are the questions that are coming up as people have clonal hematopoiesis clinics around the country. And I've heard some of my colleagues say that they would argue for a less intense breast cancer therapy to avoid a therapy-related leukemia later. And I think that's a dangerous recommendation because we don't want to undertreat the disease right in front of us. She has to get past this breast cancer. And I think we can just follow her very, very closely on the heme side afterwards. But that's a point for discussion and for more research for the future. Now, I've touched on age a little bit. It's been a theme in our work because I do think the age at which you present matters. And I think it matters because it's reflecting the biology. So we've looked at MDS across the ages, and the pediatricians have been doing the same thing. Remember, the average age of diagnosis of MDS is 72 in the United States. So why is a 5-year-old getting MDS? I mean, that's way out of whack, right? And so the pediatricians have done this. And if you're a 5-year-old with MDS, you probably have inherited SAMD9 or D9L variants. In the teenage years, especially with monosomy 7, it's got a 2. In the young adult age, from 18 to 40, it's DNA repair and telomere biology. And then there's DDX41 that presents in exactly the expected age range. So you see there's that gap. We tried to fill that gap. We did that by working with the International Bone Marrow Transplant Registry. Now, the CIBMTR only stores blood. And another theme that I kind of harp on is blood is the worst tissue to do germline genetics in. I know it's what genetic counselors have been taught to do, but we've just been talking about clonal hematopoiesis. So how do you distinguish a large clone from germline? How do you distinguish from somatic mosaicism? Embryonic level somatic mosaicism. So it's not ideal. We try not to use it, but in this case, it's all they had. So we took 400 MDS patients and 400 related donors. The first thing was even to get the CIBMTR to agree to do it at all, because initially they said, well, we wouldn't have used affected donors. They would look funny. Their thumbs would be funny. Their counts would be funny. Their physical exam, you know. And then they realized, well, unless we do the study, we don't know. Maybe we have let these people come through and be donors. So we made DNA from the blood, we sequence it from the patient and their relative, and then we pay a lot of attention to mode of inheritance, and we do a lot of curation of variants. And we do that by hand, we don't use computers. So you can see we curated over 20,000 variants. We did RT-PCR for 300 potential copy number variants. The mode of inheritance is really important. If it's autosomal dominant, you just need one bad copy, right? But if something's autosomal recessive, you need 2 bad alleles and they have to be on different chromosomes. So we only count things if they fall into those categories. So the answer that I give you is a minimum. The truth is probably higher than that. The answer altogether is 7%, of MDS is germline. Of course, there's a peak in the younger age range, because why is a 10-year-old getting MDS, right? But you see there's a tail that's over 5% in all of the age ranges. The reason 5% matters is the American College of Medical Genetics and Genomics says if your pretest probability of something is over 5%, you should do it. So to me, these data say if you have MDS and you're going to matched related transplant, you ought to have germline testing. The problem was we thought we could say something about the outcomes of those transplants when those donors were used, because the CIBMTR collects all that outcome data. The problem was it's a little bit of everything. So even DDX41, CHEK2, which are the most common inherited predispositions, we had hardly, a reasonable number, just, 2 or 3 or 4 for DDX41. It's not enough to see that if you use a donor with a change in that gene, you're going to have a bad outcome. We need to do a case control study where we take the cases of poor outcomes, the donor-derived leukemias, the primary graft failures, severe graft versus host disease, and do controls, and then we can read out which germline variants give you that bad outcome. Hasn't been funded yet, but hopefully one day the proper study will be done. Again, the reviewers of our work asked us to call somatic mutations. We tried to argue to them that we did germline level sequencing. We can't call large clones, but they said do it anyway. So for what it's worth, we called the somatic mutations. Again, there's no mutation that predicts that you have a germline predisposition disorder. And the genes I showed you to them, you can just pull that bubble of DNA repair and telomere biology across the age spectrum. Now we're doing any MDS over the age of 40. This is, in my mind, the last MDS study we're going to do. It's not requiring that someone goes to transplant, so it's all grades of MDS. And the answer is, Mikhail, 16% of any MDS over the age of 40 is germline. That's really high. And it's all grades of MDS. It's low grade, high grades, no different. So again, you can't look at the MDS by the age of the person or the grade of the MDS and know who has germline. So you just have to test everybody. And that, you can hear, is what I think should happen. Now, DDX41, we have to take a moment and talk about DDX41 because it's so important and it's so unique. And one thing that's really unique about it is that age distribution. So when we think of germline predisposition, young people, right? This is not young people. This is older people. So what in the world is going on? It just challenges everything we know. The upper part of this figure shows you the germline alleles. You can see there's kind of a pileup of certain alleles. And if you tell me your allele for DDX41, I can predict your ancestry. So A500 frame shift is Japanese and Korean. This D140 frame shift and the start loss, the M1 question mark, that's Northern Europe. There's a Middle Eastern founder, et cetera. Then in the myeloid malignancy that develops, now we have a signature. The signature is a point mutation. It's this R525H, or there's a couple other hotspots there that you can see. And so if you have an R525H in an MDS or an AML, and you have a truncating DDX41 allele, you have a germline and then the acquired mutation. 98% of truncating DDX41 variants are germline. So if it's truncating in the context of R525H, please think about the germline. We follow a lot of families with germline DDX41, and I think it allows us to make some interesting conclusions, like the M155I is probably pathogenic. At baseline, these bone marrow biopsies are not normal. So again, I think it's very important to do baseline bone marrow biopsies when people are healthy, because the cells don't look so healthy, and you don't want to overcall MDS. You can see the youngest person we've done a baseline bone marrow biopsy in is 17, even as young as 17. The cells don't look so normal. Now, this is the description of the malignancies that they develop. You see, they develop malignancy over the age of 50. So something is going on as these people age, which is not what we think of in terms of germline. And you can see the teal and the black, there's a lot of solid tumors. And so what's going on with that? So we think that the DDX41 is directly causing the myeloid malignancies because just like in the argument for BRCA1 and 2, you're hitting the wild type allele. You either lose 5q to get rid of, this is on 5q, you usually lose 5q and lose the wild type allele, or you mutate the wild type allele. So in terms of those solid tumors, do you see the same thing? Do you see R525H in a breast cancer that develops in someone with DDX41? And you can see, why do I use breast cancer as an example? Well, if you look at these pedigrees, you see this really curious thing. When there are solid tumors in the family, they often have other cancer risk alleles. So we do very, very broad cancer risk testing. Our average panel has about 145 genes on it. And you start to see this, DDX41 with BRCA, DDX41 with APC, DDX41 with, name any cancer risk disorder that you know, Lynch syndrome, CDK, et cetera. So if the DDX41 is directly causing those solid tumors, you'd think they have the R525H, right? So that's just the table showing you that if you have solid tumor in your family, you're more likely to have DDX41 with something else. This is just trying to see if there's a genotype-phenotype correlation, maybe, but the numbers are small. And again, older ages. So here's the sequencing, and basically it's no in the column all the way to the right. You never see R525H. So if the germline DDX41 has any role in the solid tumors, it's indirect, is what I would argue. And so the model would be, again, if the DDX41 is playing a role, it's providing an inflammatory milieu. DDX41 is important in CGAS sting, innate immune generation, the interferon pathway. Or maybe the immune system isn't working so well, and so it doesn't detect the solid tumor, but the solid tumor we think is being driven directly by a different pathway. So now we're doing mouse models of this to test it. Now, why do I invoke this inflammatory milieu? Well, first was an observation from the clinic. So for these germline predisposition disorders, we tell people, just transplant you with wild type stem cells, everything is better. Except for the DDX41 individuals, they were dying of graft versus host disease. And this isn't so many years ago. I mean, this is with lots of drugs for GVH. And this GVH is absolutely not controllable. The normal T cells coming out of the graft are hyperstimulated and you cannot stop them. So it was horrifying. And I started calling around to different centers at the time where genotyping for DDX41. Now it's very common, but at the time it wasn't so common. And half the centers said, yes, we see the same thing. And half the centers said, no, we never see it. So we compared the transplant regimens. And it turned out if you use post-transplant cyclophosphamide, you didn't see this effect. So we think that post-transplant cyclophosphamide just tones down these wild-type T cells and prevents this. So we're very particular to know the DDX41 status of our individuals coming to transplant because our transplant team doesn't use post-transplant cyclophosphamide for everyone. If you're a transplant center that always uses post-transplant cyclophosphamide, you don't have to genotype. You're taking care of it. But I'm very insistent that they get this treatment if they have DDX41. Now, we also have cell lines, lymphoblastoid cell lines that we've made from these individuals. If we do RNA sequencing from those cells, you see they're expressing more inflammatory cytokines. You can look at the protein levels, and the proteins that they're making are with more inflamed molecules. We can look at nuclear localization of NF-kappa B, which is downstream of this pathway, and it looks like, yes, you have more activated NF-kappa B. So this is a little bit of a cartoon. Again, from LCLs, you could say, like, who cares about an EBV transformed lymphocyte that's in your lab? So again, we went to the UK Biobank. The UK Biobank has done proteomics on 50,000 individuals. And the proteomics is good. It's 3,000 proteins being measured. It is one time point in this person's life. So we said, out of those 50,000 people, how many had germline DDX41? It turned out at the time we did it, there were 49. Today there are 50. But 49 is not zero. So we said, okay, let's look at those 49 people with 2 times the number of age and gender match controls. And it turned out there were lots of proteins that were different. And if you do a protein interaction map, the proteins that are lower are actually quite tightly coordinated, and they're all about T cell function. So These people in UK Biobank, average age was about 55, so that's about 10 years before they're going to get their myeloid malignancy. And I would say their immune system is not so normal. So, you know, more to do. I think what we really need is longitudinal study of people over time, because you really want this assay in the same person for the next 10, 15 years. So I'm hoping the NIH will open a DDX41 clinic, and we can all send our patients for longitudinal work at the NIH. I think that's the only place that's really going to be able to do this in the United States. Just in the last minute or two, I probably covered most of this kind of practical for the people seeing these patients. Right now, we're not doing testing on everybody, but I think soon we will, I hope. Right now, if someone has multiple cancers, again, I don't care what the order of the cancer is, we do germline testing. Yesterday, I saw an individual sent to me on her 4th cancer. I think that's way too late. When she had the 2nd cancer, why did someone not think about the germline? If someone gets a cancer much, much younger than the average age, something's going on. But remember that even if someone presents in the average age, something can still be going on with the germline. And that model I give you for MDS across the ages, we can put multiple myeloma there as well. So young onset myeloma is LSD1, average age myeloma is BRCA2, CHEK2, and ATM. In Chicago, I don't know what you'd have here in Miami. It's all about your population. We pay attention to family history, we pay attention to other heme abnormalities, and we do a lot with sequential NGS testing done by pathology, because as people come in and out of remission with a heme malignancy, that variant always stays the same when it's germline. Soon, I hope we're doing everybody. All cancer patients probably together, about 10% are germline. That's the algorithm that I kind of went through. We pay a lot of attention to people and try to do that. Skin biopsy is how I prefer to do the testing at the time of the bone marrow biopsy, because you're already doing 95% of your skin biopsy. That's what germline looks like in terms of VAF. It's a horizontal line. So how do you describe? Well, again, you can draw it out for different patients. I highlight there a couple people with Li-Fraumeni syndrome. They do not fulfill any clinical criteria for Li-Fraumeni. They're presenting with heme malignancies. Li-Fraumeni was described based on solid tumor ascertainment. So again, it's all an ascertainment bias. BRCA1 and 2 are not typically somatic in heme malignancies. They're typically germline. That's why the curve is much more horizontal. And that is the mathematical description of a horizontal line. The variance of the VAF is very, very small, right? It's just a horizontal line. Whereas a somatic variant comes and goes, the variance is much larger. So if you calculate the variance of the VAF, you can predict who has germline predisposition. We do a lot of cancer surveillance. They can be scary. Like a few months ago, I had a 32-year-old woman who came with CHEK2, and she said, I want to have my breasts off. I want you to refer me to the breast surgeon. I don't want these breasts. I don't need them. And I said, well, let's do your cancer surveillance first. So we started with a thyroid ultrasound, and she had a 4-centimeter thyroid nodule, biopsied it, it was thyroid cancer. She went to surgery, she had 2 lymph nodes positive, and she came last week and she thanked me. She said, you know, without that surveillance, I don't know what would have happened. Completely silent, right? She had no symptoms whatsoever. So again, the people are a bit like whack-a-mole. We do a lot of surveillance. We could talk about, I do surveillance chest MRIs in people who've had mastectomy. Mastectomy only removes 95% of the tissue. I don't get pushback from insurance companies or radiologists, and we've diagnosed chest wall recurrence with that MRI. So lots to talk about and change, and hopefully we'll end here just by saying germline predisposition is common. Please think about it as you're seeing people paying attention to NGS studies, and I hope very soon that our therapies will change, like I showed you for transplant, depending on knowing the germline risk. So thanks for your attention.
Dr. Godley, that was just terrific. I hope everyone here appreciated what an incredible presentation that was. You effortlessly,
Thank you.
Much easier than I just said that word, present in basic science, you translate it to the clinic, you weave in stories that'll make it stick to our memory, and also give us the practical way of assessing people who have germline mutations. It's really incredible.
Thank you.
So thank you. What a privilege it is to have you here.
Thank you.
And I'm not just blowing wind in your sails. I
No,
never
you just
compliment
did it.
anyone. This is.
Any questions?
Well, we do. So
Oh.
actually, the boss has a question. Yeah, he put it in the chat.
Okay.
The boss is Lazarus Lakakis, who's one of our transplanters, and we actually predicted he would ask a question as soon as you started talking about transplant. What is the role of donors' germline mutations or of CHIP in donor-derived leukemia?
Yeah, it's a great question. So, and more scary stories. We had a 12-year-old girl, the daughter of the patient. He's a doctor with MDS, so his 12-year-old was going to be his haplo donor. What could go wrong, right? And they used the haplo donor. He died after transplant. But before he died, they did a bone marrow biopsy because he wasn't doing well. They did NGS when he's 100% donor. So who are they sequencing, right? You're sequencing the donor and identified a germline PALB2 variant. Then you take the mother of this donor, right? The wife of the patient, take her family history, and there's breast cancer all over the family. So the 12-year-old had inherited her mother's germline PALB2. And I wonder if that was part of why the stem cells didn't work so well in the patient. And we, about maybe twice a month now, we get referrals from transplant, either unrelated donors or related donors who have germline predisposition alleles. They are identified after those cells go into the patient, and we do NGS on day 30 from the transplant. So now you'll ask, from the CIBMTR, you did a study with related donors. Doesn't the CIBMTR use unrelated donors? So the answer is yes. And after we published that work, the CIBMTR said, hey, we have another 500 MDS patients who were transplanted, a third of them with related, 2/3 with unrelated donors. And we sequenced them for another study. Would you like to look at your parts of the genome and do, another 500 people? So the answer is yes, we did. From UK Biobank, again, we can tell you that cancer risk is common. 3.6% of the UK Biobank has pathogenic or likely pathogenic, likely germline variants in any gene. And would you like to guess what the unrelated donor pool is from CIBMTR? If a regular healthy population is 3.6, what are the donors in the CIBMTR pool? So excellent. You'd say higher than the general population. And why do you say it's higher? Who puts themselves in the registry? The average person on the street, or somebody whose brother had cancer, or somebody whose uncle had cancer, right? So the answer is not 5%, it's 4.6, but you got it very close. I don't know if that's the same as UK Biobank, but it's definitely not lower, right? And so cancer risk is common. I don't know why we were ever taught that cancer risk is rare. It is not rare. Cancer is a common disease, and inherited risk is common. And so where we see donor-derived leukemias after transplant come either from unrecognized germline predisposition in the donor. I think it's absolutely wrong to use germline RUNX1, CEBP alpha, or GATA2 variants, mutations. Those are master transcription factors. Those stem cells are not going to work. They are not going to differentiate. We have primary graft failure from heterozygous MIPL from unrelated donors. That turns out to be a really important signaling pathway. Who knew? Right? Or clonal hematopoiesis, unrecognized in the donor, that reads out as a donor-derived leukemia because that donor had step 1, right, had clonal hematopoiesis. So I think all patients and all donors, whether you know what their face looks like or not, should be sequenced. And I don't know why in Chicago, we do West Nile virus and chikungunya serologies on 100% of our donors. We don't have those diseases. We definitely don't have chikungunya in Chicago. We do that on 100% of people, and we don't do what exists in 5%.
I thought I had that in a Hungarian restaurant once in Chicago. No.
Anyway, I want to change how things are done.
And in the future, Dr. Venugopal, when you guess, you've got to go to the 10th.
Exactly.
With
We
Dr.
do-
Godley.
yeah,
Rounding up won't count.
Exactly.
So I have a question from the real boss,
Yeah,
Dr. Weiss.
Yeah.
Are there any examples of deleterious germline mutations that are associated with protective mutations that may negate the deleterious effect?
Yeah, we'd love to know that. And we don't know it right now because we haven't been able to do outcomes. We want to do that case control study. But in this case, you could also imagine doing, long-term survivors of transplants, what germline alleles lead to that. So we don't know, but I'm sure there are protective alleles.
Yeah.
I'm sure there are modifier alleles, right? We don't
They're
know.
harder to find. If they're protective, you're not, obviously people
Well,
aren't getting the.
like the super responders, right?
That-
People
that-
who.
So would that be protective or would that be predictive, right? So that's hard. That's a
Yeah.
hard question.
It's a hard question.
Dr. Venugopal.
Yeah. Yeah, I guess the first thing is it really a VUS? Because, so we check ClinVar for every clinical report we get because the companies make their own decisions and we play games. So the other day I had a patient who has HHT and he has a variant from one lab that's called a VUS, but when we look it up on ClinVar, there's a lab that calls it likely pathogenic and everything segregates in his family. So we just resent his testing to that company because I want to do proper screening for him. But if he holds a clinical report that says uncertain significance, the insurance company may not pay for it. So that's a problem. Conflicting variant classification is a huge problem for patients. So we play the game of getting them a pathogenic report so that we can justify what we think is right. But if it's truly a VUS, then it's not clinically actionable. So if ClinVar, if multiple companies all agree that it's uncertain significance, it's truly uncertain. And we don't know, most of those become likely benign as more people around the world are sequenced. So we would take a family like that to research and we segregate the variant in the family. The more segregations you have, the more you can implicate that it's pathogenic. So we do not do anything clinically unless we have a likely pathogenic or pathogenic variant. Yeah. Justin?
Dr. Taylor.
Check too, because I think your case, the sibling had it.
Yeah, exactly. So we've calculated the penetrance from the UK Biobank. Penetrance for all cancers, 30%. And penetrance specifically for myeloid malignancies is about 2.5%. So it's rare, but it's statistically significant.
We have one other question online. You've made a great case for us checking for germline mutations and mentioned some cases of what people did when they learned they had one. In general, though, if we screen and someone screens positive, what do you suggest we advise them to do?
I believe in surveillance because I see what happens, right? A 30-year-old who's got, lymph node metastasis from thyroid cancer that you never would have found otherwise. Chest wall recurrence, like we think of mastectomy as that's all you need to do. There's no recommendation to do any imaging of the chest wall after mastectomy. But I do it just because I know 5% of that tissue is still on the chest wall. And then you find stuff. So we do a lot of cancer surveillance. I mean, that's what our clinic does. Once we diagnose people, then we give them these surveillance recommendations. So yeah, I think surveillance makes a difference.
Yeah, and just as a plug as well, if you do find that a patient has a germline mutation that may predispose to hematologic malignancies, we do have clinics that will follow them here. So absolutely for the same reason. I think we are at the anointed hour. Dr. Godley, thank you,
Oh,
thank you
thank you
for
having
traveling
me.
here.
Yeah.
A superb presentation.
I can stay, yeah.